So let's start the session. Bismillahirrahmanirrahim. Assalamu alaikum everyone. I welcome you all on behalf of Pakistan Endocrine Society. My name is Dr. Sumaira Batul and I am a consultant endocrinologist and assistant professor at Aga Khan University Hospital. I am delighted to moderate today's webinar, which is a part of a significant initiative by Pakistan Endocrine Society aimed at advancing education and understanding of an essential topic, puberty and its related disorders. Let's formally start the session with Tilawat-e-Quran Pak.
بسم الله الرحمن الرحيم قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد.
Jazakallah. So the theme of our session is Demystifying Pubertal Disorders, and it will be presented through a series of events. There will be 2 webinars followed by a full day symposium in the major cities across Pakistan at the same time. So today is the first webinar of this series, and it is mainly focused on the male and female reproductive physiology, featuring our 2 distinguished international speakers. Let me first introduce you to our panelists. We are honored to have an esteemed panel of experts who bring a wealth of knowledge and experience to this discussion. First of all, we have Dr. Aisha Sheikh with us. Dr. Aisha Sheikh is a president of Pakistan Endocrine Society and a consultant endocrinologist at Aga Khan University Hospital. She's a recognized tutor at University of South Wales, UK. Dr. Aisha Sheikh is renowned for her extensive work in the field of endocrinology, particularly in gestational diabetes and women health. She has a keen interest in research and it has multiple publications in national and international journals. Thank you, Dr. Aisha, for joining us today. Our second panelist is Dr. Khadija. Dr. Khadija Humayun is a professor and a consultant pediatric endocrinologist at Department of Peds and Child Health, Aga Khan University Hospital. She is the General Secretary of Society of Peds Endocrinology and Diabetes of Pakistan. She initiated the first structured fellowship program in peds endocrinology at AKU and has been instrumental in getting this specialty recognized by the CPSP. She has a keen interest in medical education and has held the position of undergraduate and postgraduate residency program director and VC education in the Department of Peds and Child Health, Aga Khan Hospital. She has been recipient of Best Teacher Award from 2015 to 2024, Mentorship Award in 2020, and Innovation in Teaching Award in 2021 at AKU Hospital. She has more than 40 publications to her credit and has authored multiple book chapters. Thank you, Dr. Khadija, for joining us today. Our third panelist is Dr. Sadia Salman. She's a consultant endocrinologist and head of endocrinology department at Allama Iqbal Medical College, Lahore. And she's also the General Secretary of Pakistan Endocrine Society. She is one of the leading endocrinologists at Lahore and has more than 13 years of experience in the field of endocrinology. Her main areas of interest is endocrine disorders in pregnancy, and she has numerous publications to her credit with more than 20 research papers published in national and international journals. Thank you, Dr. Sadia. So moving on to our session, let me introduce you to our first speaker. We are privileged to have 2 distinguished international speakers who will be sharing their insights on our topic. Our first speaker is Dr. Saira Bano Sokwala. She's a consultant physician and endocrinologist, clinical assistant professor, and a program director at Aga Khan University Hospital, Nairobi. She will be addressing the female reproductive physiology. Over to you, Dr. Saira.
Yes, good morning and Assalamu alaikum wa rahmatullahi wa barakatuh to all of you. Thank you, first of all, to Pakistan Endocrine Society and especially to Dr. Aisha Sheikh for inviting me for this presentation. And I think I'll just share my slides and you let me know if you can see them well. Can you see the presentation?
Yeah, we can see that.
Excellent. So first thing I must say as a disclaimer is that I'm not a physiologist and especially not a reproductive physiologist at all. It's just that I have the privilege of having worked with Dr. Aisha Sheikh on one of these, the books that we published with her and Dr. Rehana, which was on subfertility. And I was actually given a chapter in this book when I was there in 2020 in Karachi. And I had the privilege of meeting a number of you at that time. So a lot of what we will be discussing today as far as the reproductive endocrine physiology of females is concerned is related to then this book chapter that I wrote, which is based on a lot of research that I'd done at that time. And a lot of references are from this book related to subfertility. So I'll proceed with the presentation. So this is going to be the breakdown of the talk that I'll have. It's a long topic, but we are just going to try and I've tried to summarize it as much as possible. We'll go through the introduction, a bit of the structure and function of the female reproductive system. I will not touch on puberty, although I'd included it initially, but I realized that there's a whole talk on normal and then abnormal puberty. So I decided to exclude puberty from this presentation. We look at the ovarian cycle, look at the female sex hormones, a bit on the menstrual cycle, and a completion with menopause and female sexual response, and then the interplay of the female and reproductive endocrine systems. So as a very brief introduction, we know that a woman's or a female's reproductive years are between menarche, which is the time of the first menstrual cycle, and menopause, right? Cessation of menses for 12 consecutive months is labeled as menopause. So when we look at the female reproductive system compared to the males, the female reproductive system is mostly located internally compared to males where the male reproductive system is primarily located externally. And the function of the female reproductive system, similar to males, is it doesn't only work for hormonal production and gamete production, but in females, what's unique is that it also is required to maintain normal pregnancy to term and in the delivery of the fetus. And so the female reproductive physiology culminating to ovulation and fertility, this is the primary aims of the female reproductive system. We can view it as a triple act theater, where you have got the prenatal development, which is the first act, where there's the development of the ovaries and the germ cells. And then you have the onset of reproductive maturity, which is puberty. And then you have the third act of folliculogenesis, which continues throughout the female's reproductive cycle, consisting of ovarian cycle and menarche, and eventually ending in menopause. So if we look at quickly the structure and function of the female reproductive system, if we look at the external anatomy, it is not very complicated. You can see that there is the clitoris and the labia majora and labia minora, and then you've got the glands. And I'll just go through quickly when we look at the functions of each of these. And this is the internal structure, the very basic structure that I've put up, which consists of the ovaries, which are the reproductive, like the core of where the reproductive system works. And then you've got the fallopian tubes with the fimbria, the ampulla, and then you've got the tube itself. So this is where your fertilization takes place and implantation then takes place in the uterus, which has the uterus, the cervix, and the vaginal walls. And so when we look at the anatomic relations of the female reproductive system, I'm sure you're all aware of that, so I'm not going into too much detail, but you can see that anteriorly there's the relationship with the bladder, and posteriorly the relationship is with the rectum and the colon system. So basically this is what we need to know when we are dealing with the female, the structure of the external or the gross structure of the female reproductive system. And of course, it goes without saying that the female reproductive system is incomplete without a mention of the breast, because of its involvement in the reproductive cycle as well, and especially for breastfeeding and lactation. So this is the anatomic or the histologic structure of the ovaries. And as we are aware, there's the cortex where there's the folliculogenesis and oogenesis taking place. And then there's the medulla, which is consisting of blood vessels and connective tissue primarily. which supports the systems of folliculogenesis and oogenesis and ovulation, as we are going to discuss in detail. And this is a bit more of a detailed picture on the right side, where you have got your follicles at different stages of development. And as you can see at this stage, you also have an ovulation taking place, and then you've got your corpus luteum. So these are just the follicles at the different stages of development. So quickly going through the functions, we know that the mons, pubis, the labia majora, minora, the clitoris are primarily involved in the sexual arousal and sexual stimulation functions. And you've got your vestibular bulbs also to support, the sexual function. You've got the vulva vestibule, which is just an opening to the vagina and urethra. And then the Bartholin glands, again, mainly involved in lubrication. And you've got your Skene's glands, which are important to produce substances which have antimicrobial properties to try and prevent UTIs happening in females. And then you've got, of course, the vagina, which is the reservoir of your semen and also forms the conduit for childbirth and for menstrual flow. And issues anywhere in these systems can lead to problems with, the normal sexual functioning of the females, and also later could contribute to fertility issues. When we look at the internal structures and their functions, ovaries, of course, as we've mentioned, it is mainly for ovum generation for fertilization, and it is the site where the female sex hormones are produced, which is the estrogen and progesterone, which prepares the endometrium mainly for implantation, and also helps to shed off when not required, when you have these changes in the structure in the different hormonal levels, as I'm going to talk about later. And then, of course, we have got the fallopian tubes, which are also known as the uterine tubes, which form a conduit for the oocyte all the way from the ovary to the uterus. And so when you've got these rising estrogen levels, as we'll talk about later, there's ovulation that happens, and then the secondary oocyte is released from the ovary, which stimulates smooth muscle contractions and uptake of the oocyte by the fimbria that we are talking about. And fertilization occurs at the ampulla, at the mid region of the tubes. And after that, there is multiplication that occurs in the fallopian tubes as the zygote now moves towards the uterus for implantation. And if fertilization doesn't take place, then of course the oocyte is shed out in the menstrual cycle. What about the uterus and cervix? Very clear. There's the role mainly that is played by the uterus, especially is for implantation and nourishment of the growing embryo, and also facilitating movements of the incoming sperms upwards towards the uterine tubes for now fertilization to take place in the uterine tubes. And of course, if there is no implantation, then shedding of the uterine lining takes place. We know that during high estrogen, under high estrogen levels, the cervical mucus secretion thins down to accommodate sperm to move in for fertilization. And we know that there are three layers of the uterus: the outer perimetrium, the middle myometrium, and the inner endometrium. And you can see the functions. The perimetrium is primarily a protective role which covers the uterus externally. Then the myometrium, it assists in menses and labor. And then the inner endometrium is the one that consists of two layers. There's the stratum basalis, which is close to the myometrium. This is not shed during menses, and it supports the stratum functionalis, which is now the one that is shed during your menstrual cycle. And then there's the lamina propria and the endothelial layer, where implantation occurs after fertilization. Yeah, and this is what is shed during menses if fertilization does not take place. So that is basically looking at the structure of the female sexual reproductive system. So we move on now to, there actually like 2 or 3 cycles. There are 3 cycles that we'll be talking about, and they are all interrelated. They're actually quite orchestrated to function in a particular way. So if you like, I'll take us through each one of them. So they're not in exclusion of each other. All these cycles are actually taking place together. So the ovarian cycle is about a 28-day cycle in a female's reproductive years, yeah, which involves certain changes in your oocytes and your ovarian follicles. So it includes 2 different processes. So there's oogenesis, like it says oogenesis. So it's the process of female gamete formation, which includes the formation of an oocyte from an oogonium, which is the primary, the structure that is formed, the gamete that is formed when there is arrival at the genital ridges, I'm going to talk about. And this is then followed by meiotic division, and we'll talk a little bit more about this. And then there is folliculogenesis, which is a process by which the female germ cell develops within the supportive structure or the somatic cells of the ovary, and then how it matures to a fertilizable egg. So these are 2 processes that occur simultaneously. So this pictorial is basically just to show us what happens in utero. So the oogenesis process actually takes place in utero. So this is basically related to oogenesis. So at week 5 in utero, the primordial germ cells arrive at the genital ridge. And at this point, they are known as oogonia. And the oogonia initially multiply by mitosis. And I believe we all understand what is mitosis. It's just duplication of the cell. So from one cell, you get 2 daughter cells with the same nuclear material as the mother cell. Whereas meiosis is where one cell gives 4 daughter cells with half the nuclear material in each cell. So just to make it clear, so there's multiplication by mitosis initially, and at this stage there is no atresia. So there's just a lot of multiplication taking place. So that by 6 to 7 weeks, you've got 10,000 oogonia which exist, and by around 8 weeks, there's 600,000 oogonia. And then after that, there is a concurrent process of mitosis, meiosis, and atresia by apoptosis. So what happens is that by 20 weeks, you have got about 6 to 7 million cells that are present. And by the time they are going through meiosis, now they are called primary oocytes. And they are arrested at a stage of prophase as we look at it. So there's 60% primary oocytes by 20 weeks and 4% are in the oogonial stage. And by 7 months, there's oogonial atresia complete. So basically now the follicular atresia is now setting in. So that at birth, you've got 1 to 2 million germ cells present, primary oocytes, and most of them or almost all of them are in prophase of the first meiotic division. So just before puberty and during puberty, what happens is that this germ cell mass from the millions reduces now to 300 to 400,000 at pubertal onset, out of which only about 400 are taken on for ovulation throughout a female's lifespan. And that is why the female's ovulatory cycles are finite. It's not infinite that throughout the life of the female, you will have ovulation and oogenesis taking place. So after the first LH surge at puberty, the primary oocytes complete their first meiotic division with conversion now to secondary oocytes. So first division happens, they are in that primary meiotic phase, but they are held in prophase, but now they complete this division and they are converted now to the secondary oocyte. And a smaller portion of the nuclear material with the, the nuclear material in the cytoplasm is extruded, and that is the first polar body, as you can see here. So this diagram basically now tells us what is happening, you can see that the first stage that you're looking at is the oogonia multiplying by mitosis and getting to the primary oocyte stage where it is arrested in prophase. Then at puberty, you get this primary oocyte completing the meiosis 1 and going on to become the secondary oocyte and a first polar body. Now, if this secondary oocyte gets fertilized, then what happens is there is a second polar body that is released and there is meiosis 2 which gets completed. And so then you get a zygote, which now starts multiplying in the fallopian tube and moves towards the uterus that we were discussing. Whereas folliculogenesis, this is concurrently what is happening. There's a primordial follicle, which goes on to now become the primary follicle, the growing follicle mature, and ovulation takes place after the extrusion of the ovum. You actually have the corpus luteum that is left behind. So when we look at ovulation, then this is just a repetition of what I've said to just emphasize. So the secondary oocyte is released alongside the granulosa cells. The first polar body disintegrates. If fertilization occurs, a second meiotic division occurs, and this changes into an ovum, and then the second polar body that is formed is expelled as well. The haploid ovum now becomes a diploid zygote upon fertilization by a sperm, and the cytoplasm and organelles that are there are contributed to by the ovum, which makes sure that there is nutrition of the zygote before implantation. Now, we know that ovulation takes place every about 28 days, but this can be variable, and it happens throughout the reproductive years. During the mid-cycle, there is increase in the levels of estrogen, so this is what happens. At the mid-cycle level, you get a higher level of estrogen coming up, and this is basically started with FSH, as I'm going to let you know in the menstrual cycle discussion. So you get this estradiol level rising, which initially will suppress your FSH, leading to atresia of most of those recruited follicles. But one follicle out of this survives, and this proceeds to develop into the dominant follicle, which then now starts secreting high levels of estrogen. So I just want you to keep this in mind as we continue with the discussion. Then this is followed by rising LH level. So this is what happens. Initially, you have your FSH. So this is how it starts. You have your FSH, which causes increased release of estradiol. As the estradiol levels rise, they suppress the FSH, which causes only one follicle to survive to become the dominant follicle. Now, the dominant follicle will keep on producing high levels of estrogen. When high levels of estrogens are produced, initially they are inhibitory to FSH and LH, but later, above a certain threshold, they actually become stimulatory. So what happens is they actually cause an LH surge. So there's a very high peak of LH level that happens. And through this is because of a positive feedback to the hypothalamus and anterior pituitary. Now the LH surge is basically the one that triggers the one dominant follicle to ovulate under the LH-mediated prostaglandin release. And ovulation just means release of the ovum from the ovary. So ovulation occurs about 34 to 36 hours after the LH surge, following rapid enlargement of the dominant follicle, protrusion of a stigma from the cortical surface as a stigma, and then rupture to release the oocyte cumulus complex into the peritoneal cavity. And then LH and HCG mediated processes actually contribute to this follicular rupture for it to be released. And remember at this point that there are other hormones that are necessary for this functioning to take place. And that is the thyroid and the adrenal hormones. And that is why when you got issues with your thyroid and adrenal hormones, you get issues with your menstrual cycle and even issues related to fertility. So what happens after this dominant follicle has now been extruded, okay, from the ovary? What happens is that there is now rapid revascularization and fibroblast migration into that remaining follicle, which now forms what we call as the corpus luteum, and this occurs after ovulation. So what is happening here? So there is the granulosa cells and the theca cells in the ovary, which are the cells where they support the ovum or the processes of oogenesis and folliculogenesis to occur, but also produce hormones, that is the estrogen especially. So the granulosa and theca cells undergo structural changes known as luteinization, and this converts them into granulosa lutein cells and theca lutein cells. And what do these things do then? So under the influence of LH, the corpus luteum is the main site now for post-ovulatory steroidogenesis following the vascularization and provision of low-density lipoprotein, which is taken up by the macrophages through the star protein, and that leads to now increased production of progesterone. So this is the rate-limiting stage, that is the uptake of the star proteins to form now progesterone through the whole process of steroidogenesis. So if pregnancy at this stage does not occur, the corpus luteum is going to stay for about 12 to 16 days. And then it gradually regresses by apoptosis to be called what is known as the corpus albicans. But if pregnancy does occur, what is going to happen? That the LH and the HCG that is now produced during pregnancy, they maintain the corpus luteum, which continues producing progesterone till about 6 weeks, when we call this luteoplacental transition that takes place. And then the size of the corpus luteum gradually reduces. So about 6 to up to 10 weeks, there's continuous production of progesterone from the corpus luteum, but then this function is later taken up by the placenta. So then we go to folliculogenesis. That's mainly related to oogenesis and ovulation. When you look at folliculogenesis, so there are two types of follicles, okay? Like we said, there's the non-growing follicles and then there's the growing follicles. So the non-growing follicles constitute majority of all the follicles, and the growing are divided into 4 phases. That's the primary, secondary, tertiary, and the Graafian follicles. So the first 3 phases are controlled by intra-ovarian mechanisms, and recruitment of each follicle takes place about 85 days. And as I said, it is FSH dependent. Okay, so the recruited primordial follicles, either they go on to mature into the 4th stage, which is the Graafian follicle, or they undergo atresia through apoptosis. So this is a pictorial that I prepared by myself, basically, so forgive the drawing. But basically, I just thought that this can really nicely take us through the whole process. So if you look at this point where you're looking at number 1, I'll just go through each of them quickly so that we can see. Can you see the presentation? I don't know why it's showing me. You can see? Dr. Sumaira?
Yes, Dr. Sarah, we can see.
You can see. Okay, so we'll just go through this step by step. So A is the primordial follicle, which is here where you have the primordial follicle, which is a single layer of granulosa cells and a single immature oocyte. Then you go on to develop the primary follicle, and then you have the secondary follicle where there's proliferation of the granulosa. These are the granulosa cells. You have proliferation of the granulosa cells, and by the final phase of oocyte growth with thicker external and internal formation, then you have the tertiary follicle, where you now have the antrum appearing. And then you have the Graafian follicle, and this is what the Graafian follicle looks like, the one down here, where you have granulosa cells, your oocyte is here, and these are encased by the basal lamina over here. And then you've got the antral fluid volume increasing, and now this is ready for ovulation. And then you've got follicular rupture at this point F, where now the follicle is released, and basically then you've got your corpus luteum forming. And then this regresses on to develop corpus albicans if you do not get fertilization taking place. So we'll just move on now to the female sex hormones and functions before we move on now to the menstrual cycle itself. So biologically active steroids include these four, that is the estradiol, progesterone, testosterone, and DHT. We are mainly going to focus on estradiol and progesterone. So these are mainly formed in the ovary, but also in some peripheral and target tissues, where you have got high substrates, for example, estrogen and androgen precursors, and can be produced by the adrenal glands and the ovary. Of course, I'll not take you through the process of steroidogenesis, but this is what basically happens. There is uptake of cholesterol, which is then changed into all these other hormones based with the enzymes that are engaged at different stages of steroidogenesis to eventually lead us to get our estrogen and estradiol as the primary hormones that are produced in the ovary itself. And so then we look quickly at the hypothalamic pituitary ovarian axis. So from the hypothalamus, you've got a pulsatile release of gonadotropin releasing hormone, which actually stimulates your production of luteinizing hormone and follicular stimulating hormone from the anterior pituitary gland, which then both of them, when you look at that, LH actually stimulates the production of testosterone from the thicker cells, and also is associated with the production of progesterone from the corpus luteum eventually through aromatase, which is converted to then estradiol. And then you've got estradiol, which is produced from primarily from the granulosa and also the thicker cells, which then actually goes on to give a negative feedback. But like I said, when it is produced in very high amounts, it can actually turn into a positive feedback and cause the LH surge that we're talking about. So again, this is the pictorial showing the different processes that are involved and the stimulatory and inhibitory roles that these different hormones have. So you've got another hormone known as inhibins that are produced by the granulosa cells. So I just want you to look at this. So GnRH, anterior pituitary, FSH, LH, right? LH primarily working on the thicker cells to produce androgens, which go undergo aromatization to then produce your estrogens, and also progesterones from the corpus luteum. And then you've got your inhibins and activins. So activins are stimulatory to the anterior pituitary, whereas inhibins are inhibitory, especially inhibin B, which is inhibitory to production of your FSH especially, right? And also LH to some extent. So if we look at the estrogens in females, we've got predominantly four types of estrogens. There's estrone, which is predominant in menopause, there's estradiol, which is predominant in your non-pregnant females, produced by the granulosa cells in pre-ovulatory follicles, from androstenedione, produced by thicker cells, as I've talked about it. And this is where there's the rate-limiting step that happens, okay? And then you've got estriol, which is the most potent form in pregnancy, and estetrol, which is produced solely in pregnancy. So it's just important to know that there are four different types. So this is where the estrogen comes from, primarily ovary, adipose tissue, and the placenta. So the functions of estrogen, it works through two distinct nuclear receptors, the alpha receptors, ER alpha, which is found mainly in the uterus and pituitary gland, but also in these other organs. And the ER beta rather, is found primarily in the ovarian granulosa cells. And just to look quickly at the functions of estrogens on the different organs. On the uterus, we have seen that it's important for preparing for pregnancy by thickening the endometrial lining, and how it does that is through proliferation of the endometrial cells, okay, in the follicular phase of the menstrual cycle. On the breast, it's also important in breast tissue development at puberty and also during pregnancy, and breast milk secretion in postpartum lactation. And on the vagina, it has an important role in proliferation of your epithelial mucosal cells, okay? And this is witnessed, and also in basically keeping like the vaginal mucosa lubricated as well. And so you can see the effects in menopause where you got drying of the vagina, and this could lead to issues with intercourse as well. On the bone, it assists in the development of long bones and epiphyseal growth fusion by having a role on both osteoclast and osteoblast activity, primarily in activating the osteoclast activity. And by suppression of GnRH release from the hypothalamus in higher doses, it actually inhibits release of LH and FSH and thus prevents, so that it has a contraceptive effect, basically. And progesterone, mainly produced by corpus luteum, as we have said, and then later on by the placenta in pregnancy. And I've already talked about the LDL uptake being the rate-limiting step, and it also acts through classical nuclear receptors, okay? So it kind of acts as an anti-estrogen by reducing the ER-alpha expression and increases your conversion of estradiol to estrone, okay? So thus leading to inactivation of estradiol. So these are the different sources of progesterone, as mentioned: placenta, adrenal cortex, corpus luteum, and in males also the testis to a smaller amount. And if you look at the functions of progesterone on the uterus, so the estrogen prepares the uterus initially, and then the progesterone maintains the uterus for implantation by stimulating your spiral artery vascular development and endometrial glandular secretions. And it actually is useful in preventing endometrial hyperplasia because it helps with the shedding as well. And in the cervix, it produces thick cervical mucus to now prevent the sperm from kind of entering after implantation especially has taken place. It has a role in your body temperature regulation, and on the pituitary we have already seen. And in pregnancy, it maintains your normal pregnancy. Sorry. So we'll touch on the menstrual cycle, right? So menstrual cycle is defined as the serial changes in your uterine lining, all the way from shedding, rebuilding, and preparation for implantation. And sorry, just a minute. So it begins from puberty and ends at menopause, right? The normal cycle length varies between 21 to 32 days, on an average 28 days, okay? And it begins with the first day of menstrual bleeding. And there are two phases in this cycle. There is the proliferative phase and the luteal secretory phase. So the proliferative phase, it starts from day 0 to 14 of the menstrual cycle and begins from the onset of menses and ends in ovulation. And it begins with increasing levels of estradiol, stimulated by the upregulation of FSH receptors in the follicles, as we had mentioned earlier. And from day 14 to day 28, this is the luteal phase is the one that is predominantly the one that is active now. And it is mediated by progesterone produced from the corpus luteum after ovulation. You see, day 14, you are expecting ovulation, after which now you have the corpus luteum, which now maintains the luteal phase. And it involves preparation of the endometrium for potential implantation of your fertilized ovum. So with low levels of estradiol and progesterone, after you have like gone through ovulation and there's no pregnancy that takes place, what happens is that the endometrium lining and the stratum functionalis, they lose its blood supply because now your estradiol and progesterone go low after ovulation after about 10 days, right? So what happens is that there is then shedding off of the uterine lining, that's the stratum functionalis during menses. And the low levels of the steroid hormone, then again, what do? They stimulate the FSH and LH release. And again, the whole cycle repeats where your FSH causes your production or recruitment of one dominant follicle and the remaining follicles undergo atresia. The dominant follicle produces estrogen, the estrogen levels increase, cause the LH surge, and the cycle repeats itself. And you can see that I'm also repeating myself a lot so that it actually kind of gets home, right? So this is a simple diagram to just show what actually is happening with these hormonal levels. So there's this growing follicle that is taking place. At this stage, you've got ovulation taking place. And what happens with your hormones, as we have mentioned, initially you've got a slow rise or a stable level of your LH and FSH. And as the estrogen levels increase with the follicle expanding or rather maturing, there is an LH surge. So your LH goes up, FSH also rises by about 4 times. And then after about 36 hours, you get your ovulation happening. And then the corpus luteum starts to produce progesterone, your LH and FSH levels gradually go down. So then that takes us to almost the end, that is our menopause. Menopause, we know, is the cessation of the menstrual cycle due to loss of ovarian follicles. I told you that the ovarian follicles are finite in females. And basically then when you lose them, you now have reduced steroidogenic capacity. And this usually comes in between 50 to 52 years, but it's variable depending on different factors and where you are. And it's considered complete after 1 year of amenorrhea. And when you are approaching menopause, your inhibin levels start to decline from the ovary. Thus, what happens is there's no feedback on the FSH. So the FSH production increases, and this in turn increases estrogen production initially. But eventually, a lot of these follicles undergo atresia, and no more follicles exist, and thus there is a drop in estrogen and the symptoms of premenopause, and then menopause set in. I'll not go into too much detail on menopause. I'll just touch one slide on the female sexual response, because this is a very, very important part which we kind of tend to ignore, or rather underplay, I think, when we are dealing with issues related to female diseases of the female reproductive system. And it's very important to understand this, that there are 4 stages. There's excitement, arousal, the plateau or the orgasm, and the resolution phase. And the biophysiologic model of female sexual response actually includes an interplay of the biological factors, psychological factors, interpersonal factors, and the socio-cultural factors. So when you're assessing female sexual response, these are the factors that need to be considered. And just touching on the interplay, so the pulsatile GnH release is affected by various factors, which is not only related to the ovarian steroids, but also to other hormones like dopamine, serotonin, and opioids. And estradiol and norepinephrine, they stimulate GnRH release, whereas progesterone, dopamine, and beta endorphins, they suppress its release. And kisspeptin stimulate the release, and this is the very important substance which is necessary for onset of puberty, and essential for both sexual development and reproductive function. And then GnRH stimulates release of FSH and LH from the anterior pituitary. FSH and LH release is also modulated by a lot of other factors like estradiol, progesterone, and inhibin that I talked about, activin, and also follistatin, which is of pituitary origin. Estradiol and inhibin have suppressive effects on FSH, whereas activin stimulates. And follistatin inhibits activin, thus it inhibits FSH production and release indirectly. And LH stimulates theca cells and androstenedione production, whereas FSH controls follicular growth and granulosa cell production of estradiol and inhibin B. It's just a summary of what I've said. And after ovulation, LH stimulates estrogen, progesterone, and inhibin A production by the corpus luteum. So to conclude, the female reproductive system is a complex interplay of both structural and neuroendocrine processes initiated in utero as part of normal embryonic development and proceed to mature with increasing age. And the final goal is to ensure maintenance of normal secondary sex characteristics and eventually ensure procreation. And so disturbances in the physiology form a significant cause of male and female related subfertility and infertility and pubertal disorders as well. So I will conclude by this slide, which is an orchestra. So I believe and I feel like the female reproductive system is actually an orchestrated event whereby one hormone stimulates the other hormone, and inhibitory processes also happening with this beautifully orchestrated system that is built in all of us. Thank you very much.
Thank you, Dr. Saira, for such a detailed and enlightening presentation on female reproductive physiology. Now we have our second speaker, Dr. Ahmed Matawi, with us.
Hello.
Hello, Dr. Ahmed. Welcome. Dr. Ahmed Matawi is a head of critical care and outpatient department at Clinical Nutrition Unit, Al Haram Hospital, Egypt. Dr. Matawi is a highly qualified with an MRCP, specialty exam in endocrinology, MSc in endocrinology, and is currently a tutor at University of South Wales, UK. His expertise spans a wide range of topics, including reproductive endocrinology and lifestyle medicine. He has multiple publications in peer-reviewed journals and multiple book chapters in his credit. In addition to his inpatient practice, his primary care practice provides a combination of lifestyle medicine, endocrinology, and clinical nutrition services. Dr. Ahmed is very passionate about the topics like resistant obesity, reproductive endocrinology, osteoporosis, diabetic foot, malnutrition, and efficacy of lifestyle intervention in managing the root causes of disease. He aspires to achieve the highest reproductive and metabolic health and to guide his patient down the same path. We are excited to hear his presentation on male reproductive physiology. Thank you, Dr. Matawi, for joining us today. Over to you now.
Thank you so much. I'm trying to share my screen. I might not be able to run the video, but I'm going to share the presentation now.
That's fine.
Okay. So let's start. Thank you so much for the amazing introduction. I probably wouldn't say more in addition to that. So I believe we are here today to stick to the theme of the conference, demystifying the basics related to puberty and physiology and other things. Maybe it will help people and physicians and attendees to understand more the disorders they face in their daily practice on a slightly advanced level than what they usually have been taught. So, what's today's agenda? I'm going to try to run quickly a few basics about the embryology and how the system of hormones starts working from the time during the life in utero, and then what happens in the circuit near the after birth, and then what stimulates the pubertal the start of puberty. Then we will get an idea about what the adult axis looks like and what circadian rhythms to expect and what functions to expect from the hormone. Then we will move on to discuss the effects of aging, effects of change in weight, energy availability, stress, effect of sleep, effect of acute and habitual exercise on the secretions of the various hormones. So basically how it started. In the previous lecture, you probably have had an idea about how things work and how the initial cells migrate to the places where they form the initial gonads. So primordial germ cells arrive on the genital ridges and then form the Sertoli and the interstitial cells. These including the Leydig cells. This happens by the 6th week. Okay, and then in the case of males, what guides the process is the SRY gene on the Y chromosome. At this point, something important happens is that the Sertoli cell protects these cells from undergoing meiosis. Okay, and also stimulates and promotes the differentiation of Leydig cells through many paracrine factors like anti-Mullerian hormone. The maternal human chorionic gonadotropin starts stimulating the Leydig cells to secrete testosterone, and then later on it becomes the function of the LH secreted from the fetal pituitary. The gonadotropins from the fetal pituitary, they start expressing the LH and FSH. This starts to be detected around the 8th week, and lactotrophs start to express prolactin by the 13th week. Testosterone secretion starts about the 8th week of gestation and guides the further process of differentiation of the male genital system. Okay. After birth, what happens postnatally is that something important happens is that the system is gets free from the inhibition of the maternal estrogen exposure. The estrogen used to shut down all the gonadotropins. So after this is removed, because now after birth there's no longer this amount of exposure, there is a surge in gonadotropins and testosterone. And in this case, postnatally, the surge is more an LH, more than FSH. And then afterwards, after this surge, there's a continuous decrease in the levels. Starts like after the second month, after this surge, and then reaches prepubertal level by the 6th month postnatally. Another thing is that the FSH declines till it reaches the prepubertal level after that by the 9th month, and then inhibin B goes to reach the prepubertal level by the 15th month. So this important sequence is vital for the spermatogenic potential. Like in some diseases, when there is there's a premature decline in the FSH, not by this sequence, they cannot reach the full spermatogenic potential later on when puberty happens. At the start of puberty, around like say 12 to 15 years in males, no one is sure how this happens. There are many theories about the stimulus for the puberty and what actually guides this process. But let's say that there are a few theories like the somatostat theory, where in simple terms, when the body reaches a certain amount of maturation, or the amount of body fat, or the amount of stores, this signals the hypothalamus through multiple things, maybe leptin, maybe insulin, others. And this results in the start of the spark of puberty. Usually, the most studied compound in this area is the Kiss-15. And this actually is released from the neurons in above the hypothalamus, and this is secreted in certain pulsatile manner that runs the start of puberty. So again, no one is completely sure if this is actually the whole picture, okay? But at least the pulsatility of this Kiss-15 around the correct time starts the process. Also, some people are actually prone to getting delays in or early puberty because of exposure to certain compounds we call the endocrine disrupting chemicals, like the dioxin, the PPA, the PCBs, and the diacetylbutyrol and others. This can disrupt the pubertal process. So moving on, what happens when this spark starts the pubertal process is that LH and FSH are stimulated mainly at first during the nocturnal sleep because of the intermittent GnRH bursts, and then afterwards they stimulate the cells in the testes, the Sertoli cell and the Leydig cell, and together with the paracrine testosterone from Leydig cell, they start the first sign of puberty, which is testicular enlargement. So this is just briefly covering the embryological and the someone saying voice issues. I don't know if I think people can hear me.
Dr. Matabi, we can hear you.
Okay. So what about the adult axis, full adult axis that people get after they run through the puberty and then continue with this axis throughout their lives? This looks something like this. So basically, right now there is a level at the hypothalamus area where there has been lots of attention and research going on, and they started to understand that there is the KNDY neurons, where the Kiss15 neurons in the hypothalamus in the infundibular nucleus. This is in the primate-related species. Non-primates, they have it in the like rats and so on. They have it in the arcuate nucleus. So this in the infundibular nucleus in the Kiss15, which is actually auto-regulates itself using the neurokinin B and which stimulates it, and dynorphin, which inhibits it. This constitutes the initial part of the axis. Moving on from the hypothalamus, there is a release of GnRH, which guides the anterior pituitary part, the gonadotropes, to secrete the FSH and LH. What happens next is that LH will act on the Leydig cells to secrete testosterone into two areas, in the circulation and inside the testis itself, to exert, together with the FSH, a paracrine action from testosterone here and the endocrine action from the FSH. Sertoli cell will start doing its job, but at the same time will release inhibin B and estradiol E2 in order to exert a negative feedback on both the pituitary and the hypothalamus. The negative feedback is also through the testosterone, mainly also through the estradiol conversion using the aromatase enzyme. And this acts also on both the pituitary, and the testosterone actually can act also by itself on the hypothalamus. So this is a brief description of how the axis runs in adulthood. Moving on to give a further idea about the sexual hormones or reproductive hormones in men and their circadian rhythms and functions. Sorry about this. So LH and FSH, they basically have this pulsatile manner of secretion where every 90 to 120 minutes they are secreted they are secreted in the circulation. Testosterone has a diurnal variation, and this diurnal variation is lost by many means, normally because of the process of aging. This diurnal variation, that's why we order the test at the start of the day at around 8 to 9 a.m. This is where it's expected to be at its highest. Also, it reaches its nadir or lowest level at around 8 to 9 p.m. So basically, testosterone is bound about very tightly to sex hormone binding globulin. About 44% is bound like this. And about 54% is bound weakly to albumin. 0.5 to 3% is free testosterone. That's why when we are assessing testosterone as a lab, it's better to calculate using the androgen-free index or a bioavailable testosterone equations, taking into consideration either the sex hormone binding globulin only or together with albumin. Because sometimes the free testosterone is not reliable. It differs according to many things, including if the lab is using the right method, and can differ from lab to lab, and there are many things that can influence the free testosterone. That's why the guidelines didn't actually recommend using this all the time when you're assessing the serum testosterone. Dihydrotestosterone is produced using 5-alpha reductase enzyme, and it acts. It is produced from testosterone. It has further actions of testosterone on certain tissues, including the male-related patterns of either in excess it can produce a male pattern baldness, or act on the prostate and can enhance its proliferation and so on, and can have also different androgenic action and can stimulate the estrogen receptor beta as well. Testosterone, as people know, it's important for libido, it's important for normal sexual function, including the erections, and also for sexual maturation, the hair distribution, deepening of voice. it's expected to increase the muscle mass and reducing the fat mass. But over the years, these functions has been attributed to the conversion to estradiol. Okay, especially the bone mass that's we're going to see in a minute, and it has a role in erythropoiesis. And sometimes when there's an unexplained anemia, this can be one of the solutions if there is nothing else to judge regarding the anemia. Circadian rhythms, moving on to talk about estrogen in men. Estrogen, we have actually 3 types of estrogen, but 2 main ones are the estradiol E2 and estrone E1. They are converted from testosterone and androstenedione, respectively, using the aromatase enzyme. The estrogen, as we have pointed out when talking about the adult axis, it suppresses the GnRH through the receptor beta and suppresses the kisspeptine through the receptor alpha and reduces the pulses of LH and FSH. It also directly decreases the testosterone biosynthesis and spermatogenesis. It is actually implicated in the male sexual arousal and aggressive behavior, important for maintaining bone health and maintaining the bone mineral density, and actually the tendon health as well, which is why sometimes when people use the blocking aromatase receptor antagonists or aromatase inhibitors, the people who do the doping using anabolic steroid, if using testosterone together with something like this, they can end up with tendon rupture. They when it's studied in certain cancers, they discovered that sometimes a bone mineral density has started to become affected. So estrogen is vital for many important functions in males. One of the other things is proliferation also of the prostate. And depending on the type of estrogen and the level, there might be different effects on the prostate itself. And estrogen has been implicated actually in, or estradiol has been implicated in the benign prostatic hypertrophy. This actually because of the stimulation of estrogen receptor alpha, and beta is actually stimulated. When it's stimulated, it inhibits this process. So that's what also part of the functions of estrogen in males. Estrogen also has an effect on adipose tissue. This is actually more in women, but generally speaking, it decreases white fat cells and increases the thermogenesis or the burning rate of that happens in the brown cells. So moving on, what about prolactin in males? Prolactin has a function related to fructose utilization, glycolysis, and glucose utilization in the sperms. Its excess decreases the gonadotropin pulsatility and suppresses the testosterone. Normal pattern is that it has also pulses every 2 to 3 hours and peaks in the early morning and during rapid eye movement sleep. And we will talk about sleep more in a minute. Progesterone actually exists in men, and actually it's like the precursor of many of you have seen the steroidogenesis chart in the previous session. The progesterone actually is like a precursor to many steroid hormones, but its role in men is unclear. There is some theories that, or observation that it might be beneficial for spermatogenesis, but when it's taken exogenously, it can actually suppress the gonadotropins, and it's part of what they call the male hormonal contraception. So that's why it's one of the forgotten hormones. I don't know if I should be keeping track of this. Okay. So what about effect of aging? So as a rule of thumb, testosterone level declines about 1% every year. Okay. On the other hand, the bioavailable estradiol decreases actually, but very slight decrease, about 0.3 picogram per milli per year. In addition, if we were to show the effect of aging on testosterone, sex hormone binding globulin, LH, and free testosterone, while actually keeping things stratified according to body mass index, according to the body weight. We can actually guess what's going on here because we have two things in this regard that can affect the axis. So basically, aging doesn't seem to affect much the total testosterone. But what's hidden behind this is that the sex hormone binding globulin increases with age. And of course, if you, I'll move towards the BMI in a second, but as we can see here, the free testosterone declines because the sex hormone binding globulin is increasing. So while having a constant total testosterone, that means that the available testosterone actually declines with age, and it has a significant decline. At the same time, LH is actually increasing with age. So we can say that aging appears more like a primary hypogonadal dysfunction type of process. That's where LH is increasing to try to have the testes secrete more testosterone or work with more testosterone, but actually the available one is becoming less. So that's effect of aging. But at the same time, actually, the BMI, the higher the BMI, and this follows the same process of aging when people of the same BMI are actually aging. So the higher the BMI, the lower the total testosterone and everything else. Actually, you start at a lower level. That's like, as we can see here, testosterone of people with BMI of 25 to 29, which is the overweight category, have a better level of total testosterone than people of the BMI of more than 30. And these actually are the best in people with normal BMI. Of course, here they haven't examined the people with malnutrition or whatever, but we will get an idea about how this is going to affect the whole axis. So the same also can be said as true regarding sex hormone binding globulin, regarding LH and free testosterone. So the worst, you always start at the lower level regarding any of these. So what about increasing weight and obesity? It seems to exert some sort of a secondary hypogonadal effect more than its primary. Aging itself has like a primary hypogonadal dysfunction, but the obesity exerts a secondary hypogonadal effect. And this will be more apparent when we discuss weights now. Okay. So what about energy availability, weight, and stress, as how it affects the axis? So in general, if you have a major event in life, like a loss of a spouse, a loss of a parent, this can actually drop the testosterone level as much as 10 years of aging. What about significant weight loss? Like 4 to 5 kilogram per meter square, that's a huge, significant amount of weight loss per person. That's almost approaching 20%. Okay, so this also impacts the axis as much as 10 years of aging. Low energy availability in a sense is how much energy or calories someone is getting after you subtract the other expenditures that's not related to growth or functioning or whatever. So for example, if someone is an athlete and they exert burn like 100 like 300 calories, for example, and you are giving them 2000 calories, then the energy availability here would be 1700. Divide this times the weight in as a fat-free mass or as a lean mass. This can be calculated using multiple means, and you end up with a ratio, calorie per each kilogram fat-free mass. If this ratio is less than 30, you can be sure that there will be detrimental effects on the gonadotropins in this male and female, of course. Female actually have been more studied than males in this realm, given the female athlete triad as a famous condition. So, so whenever you cross this cutoff, the 30 kcal per kg fat-free mass, there is an ongoing blunting and suppression of LH frequency and amplitude. And this can actually reach a very bad level within 1 week. This is a very weak effect. Okay, what about the other side of the equation, like we have been saying in the previous slide? The obesity, together with, for example, they think that leptin can be implicated here. They can signal early puberty in women, but in men, it's a slightly different effect. It can delay, lengthen the process in male. So higher BMI and obesity is actually associated with a relative hypogonadotrophic hypogonadism, and at the severe type of the spectrum of BMI, a severe a morbid obesity, this can actually impact the fertility, and by losing weight, this can be restored. So it's kind of a reversible process. But again, it needs more studying in order to make sure how far they can actually restore the fertility, because it's been this has been actually described as not fully studied phenomenon. Okay, so what about sleep? So in sleep, the part related to non-rapid eye movement sleep, the short-wave sleep, as you know, the short-wave sleep, it starts as a small part of the sleep, and then it lengthens throughout all the sleep cycles at night. So the accumulation of short-wave sleep actually stimulates the LH pulses. What else? The rapid eye movement sleep. And as a side note, stress and sexual orgasm, they increase the serum prolactin. Sleep onset at any time increases testosterone, gonadotropins, and prolactin. What does this mean? Is that if you, for example, did some catch-up sleep at the time of the day, it's even if it's not your usual sleeping time, there will be some release of these hormones, regardless of the time. Okay, so this is an important part to keep in mind when it comes to sleep physiology. Okay, so what about sleep deprivation? This actually impacts the androgen also very rapidly and greatly. So 1 week of 4 to 5 hours, which we actually term it as almost very short sleep, compared to 10 hours per day, this drops the testosterone by a level of about 10 to 15%. Near total deprivation, even for single night, will drop it in the morning by about 20%. Okay. Every hour lost of sleep, you can expect a drop of 5.85 nanogram per deciliter. Prolactin actually still surges, at night, even during sleep deprivation, suggesting that this is just its circadian rhythm. It's not stimulated by sleep. It's like that's how actually it works. This actually can be taken into consideration in addition to what I just said, that if you sleep at any time, these things will get released. So that's when it comes to sleep physiology. So what about exercise? What happens during exercise? And how is it different between males and females? Short bouts, you have two types of exercise that have been studied regarding the effect on reproductive hormones. You have the short strenuous bouts, and you have the habitual protracted type of exercise. So it's kind of have a different effect depending on the type that the person does. So for example, if you do short strenuous bouts, short vigorous bouts, like resistance training or sub-maximal running effort, this will cause a sharp rise in testosterone in men, but not in women. And after that, it could continue to be a level of testosterone will continue being high for a while. And this actually is accompanied by a rise in androstenedione, cortisol, and DHEA. Depending on the type of exercise stimulus, there might not be an LH rise. So there has been a suggestion that this rise during exercise is actually adrenaline origin related to the stress-related neural network, not related to the hypothalamic pituitary gonadal axis. And it seems that if you, for example, carry out aerobic exercise at 75% maximal effort, that's near the end of the moderate intensity. So if you, at first, it can actually stimulate the rise, like I said, but after about 80 minutes, 120 minutes, you will find a decrease in the level of testosterone, because that would start to become exhausting. So this testosterone has been correlated with an improvement of what they call that's in the performance. So for example, the squat, the 3 repetition maximum has seen improvement in some studies. They think that's related to the excitability of muscle fiber and neuromuscular coordination, but that's how we can translate what does it mean to have this rise in testosterone. It means improvement in performance. And this seems to be unique to males, not females. So, what about habitual endurance exercise? This actually can fall under the category of the female athlete triad. It follows the same principle. So, prolonged daily endurance exercise, like running 2 hours or more per day, probably continuous, not in bouts. This increases the negative feedback of testosterone and suppresses the pituitary responsiveness to GnRH. So, the higher the intensity during this prolonged run, the higher the more the suppression, and this can affect actually sperm concentration and motility. And these changes are reversible once you go into low intensity exercise for a while, meaning that you improve the energy available to you or improve the energy availability. So this actually can fall under the same type we discussed before related to energy availability. And this can help people to understand how people doing regular exercise can actually be at risk of overtraining syndrome, what kind of abnormalities can happen inside something like this, and how it affects fertility. That's all. I hope that this actually prepared people to understand the male reproductive physiology more. And thank you for your attention.
Thank you, Dr. Matawi, for such an informative and comprehensive presentation.
Thank you so much.
So at the end of the session, we have few questions for the participants. Mr. Anas, can you please start the questions? So the questions will appear in front of the screen of the participants. You can click on the right answer, on the right option, and the response will be submitted. So this is not any kind of exam. This is just a feedback. These are very simple questions related to today's presentation. You just have to click on the right option and submit. So in 1 minute, we will close the polls and see the result. So you have 1 minute to report your response. So we are going to end the poll in few seconds. Mr. Anas, kindly stop the poll and show us the response. Dr. Saira, are you online?
Yes, I'm online.
Can you see the results?
Yes, I can see.
So how are you liking the response?
Just a minute. Actually, it has disappeared now from my end. Let me just see. Unfortunately, I'm not seeing the results. I don't know why.
Let me check. Dr. Saira, is it visible to you now?
Yeah, I think let me just, I've gone to look for it. So, yeah, the responses are quite good actually. Most of them are correct actually. The ones that have been, majority have answered. Maybe just to take us through the questions and the, can we project the answers?
Mr. Anas can project the answers. Mr. Anas, can we do that? So the answers are visible to all the audience.
The correct answers.
The result of the polls, the correct answers are not visible. I think the results are visible, just like they are visible to you, but the correct answers are not visible. So you can mention the
Yeah,
correct
so
answers of
I
question
can
1.
actually
Yeah.
tell you the correct answers. So
Yeah.
the first question, which is a 30-year-old presenting for evaluation of infertility. So the correct answer is actually B, fertilization, and I think 52% of you got it correct. This is the ampulla. So that's where fertilization takes place. Implantation, of course, occurs in the ovary, in the uterus, right? So, and expulsion takes place at the level of the fimbria. So the fertilization is what takes place at this level. And then you have the second question on heavy menses and basically looking at which hormone is concentrated at 20 day. Remember, at day 20, you've already gone through ovulation. And so then there's the corpus luteum, which produces your progesterone. So 47% of you got it correct. Very good. So that's the correct answer. And then the question 3 is again the same, almost similar, but ovulation. So that's the surge in LH. So a lot of you got it correct. So good job.
And then the fourth question is the Bartholin's glands. And again, majority got it correct. So I think we have done a very good job. Now, in the fifth question, when the secondary oocyte is released from the ovary, what is it surrounded by? So the correct answer is zona pellucida and corona radiata. So that is option G. That's the last option, only B and C. I see there's a wide variation in that answer, but basically I think quite a good number have still got it correct. So thank you.
That's great. Thank you, sir, Dr. Sarah. So with this, we have reached to the end of our session. I would request our panelists to please comment on today's topic and today's presentation. First of all, I would request Dr. Aisha Sheikh, please share your thoughts on today's presentation, please.
Assalamu alaikum, and thank you very much, Dr. Ahmed Matawi and Dr. Saira Sofwala for your kind presence, accepting our invitation. And it's been a pleasure and honor to have both of you for this session this afternoon. And the reason we selected pubertal disorders to be discussed in Pakistan was something that we encountered patients whose pubertal disorders like precocious puberty or delayed puberty were actually not managed properly, and when they were later on coming into adult practices, there were issues which we thought that if they were handled properly in the past by their treating physicians, it would have been better for them. So that is why from Pakistan Endocrine Society, we approached Society of Pediatric Endocrinology and Diabetes Pakistan. Dr. Khadija Humayun, who is here as a panelist as well, and Professor Jamal Raza have been really kind and made that agenda. And the reason we have started with physiology and then normal puberty, embryology, and genetics is because unless we are aware of all these processes, we cannot actually interpret how a pubertal disorder, what is the reason for pubertal disorder or where the effect is actually is. And that is why, since we are all physicians who have read our basic sciences way back in maybe medical school or maybe doing our postgraduate trainings, but it's a good idea, and science has evolved over time. You can see that in both presentations, there were a lot of new data that even we were not familiar with. And for that, I will really be grateful and congratulate both our speakers for talking so wonderfully and so in a succinct manner. They have conveyed the physiological processes of male and female reproductive system so well. So, and inshallah, these two webinars, the first one today and the next, the tentative date is 24th of August. That is again a Saturday, 3 to 4 p.m. Over there, we will be discussing normal puberty, embryology, and genetics, and that is very much relevant to what it will culminate into our in-person symposium that will be held simultaneously in all major cities of Pakistan, Lahore, Karachi, Peshawar, and Islamabad. And the purpose is to then discuss all the pubertal disorders and then case discussion. So case-based scenarios, which will help you get a grasp of what is happening in these disorders and how to approach a patient and how to effectively manage that disorder. For the in-person symposium, Sami Pharmaceutical has actually agreed to help us in arranging all the logistics for that symposium, and hope to see you all in that session as well. So thank you very much. Thanks again, Dr. Sumaira, for a wonderful moderation. Thank you, Anas, Harun, Atif, for your continuous involvement with PS activities and all the IT support. And thank you very much, Dr. Matawi and Dr. Saira Sofwala. Really grateful to you. Over to you, Sumaira.
Thank you, Dr.
Thank you
Aisha.
so much.
And Dr. Khadija, your comments, please. Dr. Khadija, we can't hear your voice.
Thank you. Thank you, Sumaira. Assalamu alaikum, and thank you to PES for collaborating with Society for Pediatric Endocrinology, and it's a pleasure doing things together. And I was so happy to see that at time we had more than 200 participants attending the webinar. So excellent presentations by Dr. Saira Bano Sukwala and Dr. Ahmed Badawi. Very well covered the basic physiology. And I'm sure the foundation has been laid, and next talk when we have by Dr. Kermani towards the end of August, it would be covering the genetics and other issues, and then the in-person seminars. So looking forward to all that, and thank you for inviting me to be a panelist in this session. Very well done, Sumera. And thank you, Anas, for your support. Thank you.
Thank you, Dr. Khadija, for your time. Dr. Sadia Salman, your kind comments, please.
Thank you, Sumera. I think the purpose of the presentation has been done. Very detailed and very elaborated. A very nice presentation by both the speakers, Dr. Ahmed and Dr. Saira. Both have done a great job. And I think they have made a very good base for the future presentations. Now it will be very easy for the audience to learn more and more about the pubertal disorders, because this is not an easy job, and the pubertal disorders are they are the weak parts of the doctors. Usually, everyone cannot understand them, and now the job has done very great. Everyone can now. I think the physiology they have taught in very detail. The step-by-step approach was very good, and they have done their job very nicely. And thank you, Pes, for inviting me. Being General
Thank you.
Secretary, I'm the part of FES. Thank you, Samira.
Thank you, Dr. Sadia. So with this, we have reached to the end of the session. Thank you, everyone. Thank you again to all our speakers, to our panelists, and to everyone attending today. Your participation is crucial in advancing our understanding of this important webinar. So this is the first
Just
webinar. So,
I'm so sorry to interrupt, Sumera, but just one comment or a question. I'm sure these webinars are going to be available for those who have participated for their later hearing if they want to go back and listen to it. Thank you.
I can answer this.
this webinar is recorded, so I think the recording will be available.
The recording will be available on PS YouTube channel.
Yes.
So all our webinars are recorded and those are
Good.
there. So
Good.
both webinars will be available over there. Some people have asked about the last session being online. The last session won't be online. It's an in-person session. And in the morning, we are discussing pubertal disorders. In the afternoon, we are discussing, we are having some kind of workshops. So you need to be there to attend those sessions. So
Yeah, the
you can choose-
webinars are fine.
Yeah.
Yes, very good.
So
Good.
you can choose any of the cities which are near to you, like Lahore, Karachi, Islamabad, Peshawar. There are 4 options. You can choose any city which is near to you and then attend the in-person symposium as well.
Yes. So stay tuned for the second webinar, inshallah, on 24th August.
Thank you.
Thank you very much. I guess we can close the session now. Thank you very much, everyone.